Good afternoon, everybody. Welcome to the Southwest Affiliate Stroke Bootcamp series. We are excited to offer this 15-week course as a way to educate stroke coordinators in key components of their role, provide tools and resources to build and maintain successful programs, and to assist in building a large network of peers. Before we get started, we would like to go over a few housekeeping items. To avoid background noise, all lines have been placed on mute. For the question portion at the end of the presentation, you may unmute your line by pressing *6 or typing in the Q&A section of WebEx. Please note you will only be able to claim your CE credits at the end of the 15-week series on September 27th. A copy of today's slides and any handouts will be sent to you within a week of today's call. And for future webinar registrations, please visit www.heart.org/SWA quality. Today we have a great speaker who will be discussing cryptogenic stroke. Dr. Yagi received his MD at the American University at Beirut and did his residency training in neurology at the University of Arkansas. This training was followed by a 2-year stroke fellowship at Columbia University. Dr. Yagi is now a faculty member in vascular neurology in the Department of Neurology at Brown University. And with that being said, I will hand it over to you, Dr. Yagi. Hey, doctor, remember to press *6 to come off mute. One moment, everybody.
Hello?
Yes, we can hear you.
You can hear me? Okay. Sorry about the technical issues. It's a pleasure and honor for me to be here today. I'm going to be talking about stroke workup, the role of atrial fibrillation, and cardiac rhythm monitoring. These are the planning committee member disclosures. There are no significant disclosures. So the objectives of this talk is, number one, to discuss the prevalence of atrial fibrillation after cryptogenic stroke and its role in recurrent stroke. And number two is to identify cardiac monitoring modalities for patients with cryptogenic stroke. So we'll start by presenting a case, someone I actually have seen myself. He's an 83-year-old man with acute, who presented with acute onset aphasia and right-sided weakness that occurred 1 hour before arrival to the emergency department. His past medical history as hypertension and sinus bradycardia. Past surgical history was negative. Family history positive for hypertension. And social history, he denies alcohol, smoking, and he's fully independent prior to presentation. In the emergency department, his blood pressure was 178/91, heart rate was 68, regular, and his exam revealed an NIH stroke scale score of 22 for a left middle cerebral artery syndrome. And he had a CAT scan of the brain, and on the left side, you see the two images on the left side are the non-contrast CAT scan of the brain showing an old superficial infarct that was silent. He wasn't aware that he's ever had a stroke in the past, but the CAT scan shows an old superficial old infarct on the right side. He had a CT angiogram, and that showed a proximal middle cerebral artery occlusion. So he was given IV alteplase, and he underwent mechanical thrombectomy the next day, when I saw him, his stroke scale was 1 for a mild right facial droop, and he was ready to be discharged, but he underwent a diagnostic evaluation. He had a transthoracic echocardiogram that showed severe left atrial enlargement. He was on telemetry that was negative for atrial fibrillation during his hospital stay, and he had a BNP level that was 550. So what's the next best step? A, transesophageal echocardiogram, B, hypercoagulable testing, C, outpatient cardiac monitoring, and D, cardiac magnetic resonance imaging. And the answer is C. He underwent a 30-day cardiac, he underwent 30-day cardiac monitoring that showed no evidence of atrial fibrillation. I saw him as an outpatient after that, and we discussed doing more monitoring, and he went for an implantable cardiac monitor that was placed, and about 8 months after the stroke, he had 2 hours of AFib detected on the implantable cardiac monitor. He was started on oral anticoagulation, and he's been followed for 2 years after that without any recurrent events. So we'll start with the first objective, which is to discuss the prevalence of atrial fibrillation after cryptogenic stroke and its role in recurrent stroke. So cryptogenic stroke is defined there are several definitions for cryptogenic stroke. There's one of the oldest definition, which is the TOAST definition from the trial of ORG 10172 in acute stroke treatment. And the TOAST definition defines cryptogenic stroke as a stroke of undetermined etiology, as a brain infarct that could not be attributed to a definitive cardioembolic source, large artery atherosclerosis, small artery disease, despite extensive vascular, cardiac, and serological evaluation. A more recent definition is the ESIS definition, embolic stroke of unknown source. And actually, ESIS is a subcategory of cryptogenic stroke that selects for patients specifically who have non-lacunar infarcts in the absence of an apparent cause such as atherosclerosis, major cardioembolic source, or other defined etiology. And one of the big differences between the two definitions is that based on the TOAST definition, if patients had an incomplete diagnostic evaluation and you cannot find the cause of the stroke or you cannot determine the mechanism, then they're called cryptogenic. If they had two competing mechanisms, they're also called cryptogenic. Or if you do all the testing that's required and you still can't find the mechanism, then it's called cryptogenic. Whereas in the ESIS definition, patients need a full diagnostic evaluation before you call them ESIS. So it's actually a subcategory of cryptogenic stroke based on the TOAST definition. So cryptogenic stroke is not uncommon. About 30% of ischemic strokes are cryptogenic, and as everyone knows, about 690,000 ischemic strokes occur every year in the U.S., and about 200,000 of these are cryptogenic. And most cryptogenic stroke patients receive antiplatelet treatment for secondary stroke prevention. There are several potential etiologies in cryptogenic stroke. The most common are emboli originating from the heart, and one of the biggest risk factor for cardioembolism is atrial fibrillation. So paroxysmal AFib is one of the potential etiologies. Valvular heart disease is another one. Left ventricular thrombus is another one as well. And other sources include emboli from the aortic arch, if there's an atheroma in the aortic arch, and venous emboli can cross if the patient has a patent foramen ovale as well. So PFO is another potential etiology, or patent foramen ovale is another potential etiology for cryptogenic stroke. We know that paroxysmal AFib, on the other hand, paroxysmal AFib and persistent AFib, we know that they both carry a high risk of incident ischemic stroke. And we know that even short durations of AFib And even if it is subclinical, so subclinical AFib and short duration AFib, also studies have shown that they're associated with increased stroke risk as well. So here again, this slide shows the diagnostic evaluation of cryptogenic stroke based on the definition, and the two definitions that we discussed earlier are the TOAST definition, where the diagnostic evaluation or the workup is not specified. On the other hand, based on the ESIS definition, patients require to have an extensive diagnostic evaluation that includes brain imaging, CT or MR, 12-lead EKG. They should have a transthoracic echocardiogram. They should have extracranial and intracranial vascular imaging, and they should have cardiac monitoring for at least 24 hours before the stroke is called cryptogenic. One of the key features in cryptogenic stroke is the presence of one or more superficial hemispheric infarcts that suggestive of embolism, and this is present in up to 60% of patients with cryptogenic stroke. In fact, a study from the Stroke Data Bank showed that about 65% of patients who were initially labeled as cryptogenic had less well-documented sources of embolism upon further evaluation. And we also know that AFib is strongly associated with embolic infarcts. And this is an MRI of a patient who was admitted with dysarthria, and the MRI showed infarcts in multiple vascular territories. So you have these infarcts here that I'm showing are in the middle cerebral artery territory, and these infarcts here, this one, especially this one, is in the posterior cerebral artery territory. So whenever more than one vascular territory is involved, we think that it's likely coming from the heart or the aortic arch. And this patient had wore a 30-day monitor after the stroke that showed atrial fibrillation, and she was started on anticoagulation. So how do we prevent stroke after cryptogenic stroke? And I'm going to reference the WAR study, warfarin aspirin recurrent stroke clinical trial. And this trial looked at recurrent stroke prevention in patients with a prior non-cardioembolic ischemic stroke. WARS is a multi-center, double-blind study comparing aspirin 325 milligrams once daily to warfarin goal INR 1.4 to 2.8. Patients in WARS had a previous ischemic stroke within the last 30 days. The stroke was not associated with carotid stenosis, for which surgery was planned, and the stroke was not associated with an inferred cardioembolic source such as atrial fibrillation. And WARS showed that the primary endpoint, which was stroke or death within 2 years, was similar between the two groups, warfarin and aspirin. And this is the Kaplan-Meier survival analysis showing that there was no difference between the two. The event rate was 17.8% in warfarin and 16% in aspirin, and this was not statistically significant. If you look at adverse events, pretty much they were similar between the two groups except for minor bleeding, which was more common in warfarin versus aspirin. And if you look at stroke subtypes and look at cryptogenic, lacunar, large artery, and other, and if you look, there was really no significant difference between warfarin and aspirin across all stroke subtypes. If you look at cryptogenic stroke, there was an 8% reduction in the primary endpoint with warfarin versus aspirin, but again, this was not statistically significant. So, whereas in patients with AFib, we know that anticoagulation is very effective in preventing the first stroke or a recurrent stroke. So the first study here that we're showing in the table is a meta-analysis of the warfarin trials in atrial fibrillation. And it's comparing warfarin to aspirin, and it shows that there was about 50% reduction in the risk of ischemic stroke in patients with treated with warfarin versus aspirin. On the other hand, the lower part of the table is from the Averroes trial that compares apixaban to aspirin in patients with AFib. And what you see again, you see about a 55% reduction in the risk of ischemic stroke with apixaban versus aspirin. So we know that anticoagulation is very effective in preventing stroke in patients with AFib. However, in cryptogenic stroke, there's really no data to support anticoagulation in everyone, and this is based on the WAR study that we talked about. So, this is the current paradigm, how to prevent stroke after cryptogenic stroke, and obviously we do all the stroke prevention strategies, blood pressure control, diabetes control, and everything else. We control risk factors, but on the other hand, in choosing antithrombotic therapy, what we do is we stratify patients and we look for AFib. So if we find AFib, then we treat them typically with anticoagulants. If we don't find AFib, we treat them with antiplatelet agents. And AFib may be really hard to find. We look hard to find AFib after cryptogenic stroke, but it's really not easy to find AFib afterwards. And there are several studies looking at AFib detection after cryptogenic stroke. The first one is the Embrace trial. It's a randomized control trial that randomized patients to 24-hour Holter Monitor versus a 4-week event monitor or a 30-day event monitor. And it showed that the detection rate was about 15% with the event monitor compared to 2.2% with the Holter Monitor, and this achieved statistical significance. But one other thing you see is the detection of AFib, the rate of detection goes up the longer you monitor. So it starts with 7.4% at 1 week, and it goes up to 15%, almost 15% at 4 weeks. So the longer you monitor for AFib, the more likely you're going to find AFib. The other study is Crystal AF, and Crystal AF used the insertable cardiac monitor, the Reveal device, and they randomized patients to standard of care monitoring versus the implantable cardiac monitor or Reveal. And again, it showed pretty much the same that Embrace showed, that there's more detection with longer term monitoring than standard of care. And people were monitored for 3 years in Crystal AF who got the Reveal device, and the hazard ratio, or it increases there's increased likelihood of detecting AFib, and the hazard ratio was 8.8 at 3 years, and the rate of detection was 30% at 3 years. So what are predictors of AFib after cryptogenic stroke? One of the biggest predictors across most studies is older age, and then there are certain EKG predictors. Prolonged PR interval on EKG is one of the predictors. Premature atrial beats on telemetry or cardiac monitoring is another predictor. There are certain neuroimaging predictors as well, and one of the common predictors across studies is a prior superficial infarct. There are echocardiographic predictors, and one of them is left atrial enlargement on a transthoracic echocardiogram. In fact, a post-hoc analysis from Crystal AF showed that the 2 predictors of atrial fibrillation after cryptogenic stroke in patients who underwent the implantable cardiac monitor were a prolonged PR interval on EKG and increased age. And if you combine both, there was a moderate predictive ability to predict AFib with an area under the curve of 0.78. Therefore, because it's only a modest predictive ability, the current prediction tools may not be useful to determine who would benefit from outpatient monitoring, because if you only include patients who are at a higher risk, you may miss a fairly large number of patients who still may have AFib and are not monitored. Stroke recurrence after cryptogenic stroke is not low. This is from the Greek stroke registry in Athens, and they show that in patients with ESIS, about 7% had recurrent stroke at 30 days, and the risk of recurrent stroke was about 12 to 15% at 1 year and about 20% at 2 to 3 years. So, and we know, and as I said earlier in a previous slide, that we look hard for AFib, but AFib is really hard to detect, and because the two main reasons, most patients are asymptomatic. More than 90% of episodes of AFib are asymptomatic, and more than 30% are intermittent. So clinically, it's really hard to know if someone has AFib or not. But it's very important to detect AFib because it leads to a change in management once AFib is diagnosed. And failure to diagnose AFib will result in suboptimal antithrombotic therapy. As we discussed earlier, anticoagulation is more effective than antiplatelet therapy in preventing stroke and AFib. And we know that detection of AFib is an important goal for primary stroke prevention, but also more for, in this talk, it's more for secondary stroke prevention to choose the appropriate antithrombotic therapy after a stroke or a TIA. So this brings us to the second objective of the talk, is to identify cardiac monitoring modalities for patients with cryptogenic stroke and discuss each one of these modalities in detail. So the AFib can have a triad of symptoms. Some patients report racing heart rate, fluttering, or palpitations. Others report shortness of breath, and others report lightheadedness. However, really the vast majority of patients have no noticeable symptoms at all, or just very minimal non-specific symptoms. And the current guidelines the current AHA guidelines for ischemic stroke without an apparent cause, they recommend prolonged rhythm monitoring to look for AFib. That's approximately for 30 days. And there are several technologies to look for AFib. There's the short-term Holter Monitor, and you have intermediate-term modalities such as an event monitor, the patch systems, the mobile cardiac outpatient telemetry. You have the wearable and mobile devices, and then there are the implantable long-term monitors. So you have the implantable loop recorders and pacemakers or defibrillators. And we'll start with the Holter Monitor. So the Holter Monitor, it looks like this. Patients wear it. It has several leads that are attached, and it's usually worn for 24 to 48 hours and then returned for download and analysis. So it's a very brief duration monitoring, up to 48 hours. Intermediate-term monitors, there's the event monitor, and it looks like this, and it has a couple of leads that are also attached, and patients wear it. It offers longer-term monitoring compared to Holter Monitor. They can wear it for up to 30 days. Unlike Holter Monitor, which records continuously, the event monitor, it requires the patient to trigger recording if symptomatic. So it would record, or it would send the information only if the patient has symptoms, but sometimes it can be programmed to send information for auto-triggered events based on the heart rate, or if it's regular or not, based on certain internal algorithms. But the event monitor, there should be an event, either a patient-triggered event or an auto-triggered event to be analyzed. Other technologies, intermediate term, include patch systems, and here's an image of the patch system. It's the least obtrusive and well tolerated of the external devices, and again, it can be worn up to 30 days with several patches. Another one is the mobile cardiac outpatient telemetry, and it looks like this. It's worn continuously and automatically records and transmits rhythms. The device records EKG samples periodically throughout the day, so it's a little bit better than the event monitor because it does record samples of EKGs every day. It's not only based on auto triggers or patient triggered events. And the patients can also press the button to mark symptoms and see if there's a correlation with EKG. Other intermediate-term monitors include the wearable and mobile devices, and there are two main ones. There's the iPhone, the single-lead iPhone EKG, and then you have the watches, the Apple Watch and other watches. And these are, there are really not many studies to validate these two modalities. However, there's one study that looked at the single-lead iPhone EKG for detection of AFib, and it did show that there's high sensitivity, specificity, and accuracy in detecting AFib. So these wearable and mobile devices, it's just an evolving technology, and I'm sure it's going to improve with time. Wristband systems and watches, they rely on detecting a pulse or tissue perfusion and not on EKG recording, unlike the mobile phones they're linked to electrodes, and these provide a single lead EKG that can be used for rhythm assessment. The compliance is not well studied in a large trial, so we definitely need more studies on these kind of devices. So what are the advantages and disadvantages of external monitors? So they're viable for conventional ambulatory monitoring. They can be used for a few days up to 1 month. The data either is stored in the device or transmitted to a receiving station for assessment. There's one of the main issues with these monitoring modalities is there's limited duration of monitoring, which leads to undersampling of paroxysmal AFib. And as we know, the longer you monitor for AFib, the more likely you're going to detect AFib. So if you're just monitoring for 30 days and the patient does not have any AFib episodes within these 30 days, then you're probably going to say there's no AFib, but there's a chance that they may have AFib after the monitoring period. Sometimes there's poor data quality. If leads fall off, then you don't know if this is artifact or AFib, and so the quality of the data may not be good. Another problem is, and I see this very often, is poor compliance with wearing these monitors, and even in clinical trials, the compliance was under 50%. So even if you think that they would wear it for 30 days, they'll probably wear it for under 50%, under 15 days of these 30 days. And some of these require activation when the patient is experiencing symptoms. So again, if they have asymptomatic AFib, they're not having symptoms, then AFib may be missed if there's no auto-trigger algorithm set to detect AFib. So other technologies we have are the implantable long-term monitors. We have and then we have the pacemakers as well. So the implantable loop recorders, they're small monitors, and it looks like this. It goes under the skin, so it's inserted with a minor procedure in the office. It's usually under local anesthesia, and it's not deep, so it doesn't touch the heart or anything. It's superficial, and patients can feel it once inserted. And it can stay in up to 3 years because the battery that the device has can last up to 3 years. And it automatically detects AFib and other abnormal cardiac rhythms. It transmits data on a daily basis for review by the clinician. The device also stores representative rhythm strips to allow for confirmation. It allows also for patient-mediated activation. There's a device that the patient can swipe over the monitor if they're having any symptoms, and then the cardiologist or the clinician reviewing the data can correlate and see if they have any EKG changes that correlate with symptoms. So in Crystal AF, as we discussed earlier, the AFib detection rate was 8.8% at 6 months using the implantable cardiac monitor, or Reveal. It was 12.4% at 1 year, and at 3 years it was 30%. And in all these time frames, it's significantly more than the control group. So bottom line from the Crystal AF is that approximately for every 10 patients screened, one new diagnosis of AFib at 1 year is made with the implantable cardiac monitor, and 97% of patients in Crystal AF who had AFib detected were started on oral anticoagulation. So what are the advantages and disadvantages for implantable cardiac monitor? The biggest advantage is that it provides continuous and long-term monitoring for up to 3 years. It does not need any external monitors or wires, so there's definitely better compliance. There's complete compliance, there's better patient experience, and there's improved data quality. And one of the things that I find useful is the data is analyzed on a daily basis, and whenever someone has atrial fibrillation, it's detected immediately. And our system at my institution, I get informed the same day that the patient had AFib, and I immediately start them on anticoagulation, as opposed to other types of modalities where the monitor needs to be returned back to download the data and analyze it. So this is more of there's a rapid clinical decision made after detection of AFib, after the patient has AFib. One thing that needs to be considered is the cost. Obviously, the cost of the monitoring and the cost of inserting the device also. So it's important to identify patients in whom detection of AFib will result in a change in management before putting the device in. So if someone has a contraindication to anticoagulation, perhaps they may not be a good candidate for long-term monitoring. And then one other challenge, and it's not a main challenge in our institution, but it may be a challenge to identify the person responsible for reviewing and interpreting the data. Other long-term monitoring strategies are pacemakers and defibrillators. Obviously, patients will not have a pacemaker or a defibrillator just for monitoring after cryptogenic stroke. This is more for patients who have a cryptogenic stroke and have a defibrillator or a pacemaker in. And they have atrial leads that can be analyzed as well, and these leads can be analyzed to look and see if someone had atrial fibrillation or not. And studies have shown that subclinical atrial arrhythmias detected by pacemakers are also associated with stroke risk. And I've brought this up in the first few slides, where even subclinical AFib and brief AFib is associated with stroke risk. And this is from the ASSERT trial that included patients 65 or older with a history of hypertension in whom pacemakers or defibrillators were implanted for various reasons. And these patients were followed for a mean of 2.5 years. And in this study, about 15% of patients had subclinical AFib, and most patients with subclinical AFib stayed subclinical. They didn't develop any symptoms. The AFib remained subclinical in the vast majority of these patients. But this study showed that subclinical AFib was associated with increased risk of stroke, and the hazard ratio was 2.5 times increased risk at 2.5 years. So even subclinical AFib is associated with increased risk of stroke. Hence, it's very important to monitor patients after cryptogenic stroke, because AFib detection will change the antithrombotic treatment choice and may potentially reduce the risk of a recurrent stroke. So again, to summarize, these are the types of cardiac monitoring strategies, and this is a nice table showing them. It shows the detection of AFib using each of these strategies. With admission EKG, the rate of detection was 2.7%, and it goes up the longer you monitor. So with telemetry for 3 to 5 days, it's about 5.5 to 7.6%. With a 24-hour Holter, it's 3 to 5%. With a 48-hour Holter Monitor, it goes up to 6%. With a 77-day Holter Monitor, it's about 12.5%. With 30 days, 21 to 30 days of MCOT, it's 16 to 25%, and with implantable cardiac monitors, it's 9% at 6 months and 30% at 3 years. So as a conclusion from this talk, recurrent stroke is common after cryptogenic stroke. AFib is a strong risk factor for stroke, and failure to detect it will result in suboptimal prevention of stroke and its recurrence. Prolonged monitoring identifies AFib that would not have otherwise been detected. Minimum cost-effective duration is needed to detect possible AFib after cryptogenic stroke requires further investigation. And I thank everyone for their attention. And and this is this is a slide showing that if you want to become a member of the AHA, these are some resources and some websites that you can go to become a member of the AHA. And I thank everyone for their attention, and I'll take questions.
Thank you, Dr. Yagi. We now want to open the floor to questions. You can press *6 to unmute yourself or type in the Q&A section of WebEx. Again, press *6.
Hi. Oh, sorry about that. Hi, Dr. Yagi. This is Allison Capatillo. I have a quick question.
Yes.
I noticed that in the statistics, it kind of appears that the incidence of capturing AFib on patients who have cryptogenic stroke within 30 days seems quite low, but it looks that that incidence rate goes up as time goes on. Is that accurate? And then if that's the case, why are we not pushing for more, I guess, lengthy cardiac monitoring in all cryptogenic patients?
Mm-hmm. Yeah. So are you referring to the table or to Crystal AF?
That's a good question. It was a chart you had.
Oh, the table.
Yeah, I think it was the table.
Yes. Yes, here, I'm just...
actually, it was that slide, I think.
Here? This one?
That said it. I don't know, it just showed the incidence rate. It seemed like it went up like at 12 months, 24 months, 36 months.
Oh, yes, this is with Crystal AF. So
okay.
That's a great question, actually. What we really see, and if we go back to the monitoring studies, Embrace and Crystal AF, what we really see is at 30 days, and here, at 30 days with the Embrace trial, using the event monitor, the rate of detection was 15%. Whereas at 30 days in Crystal AF, it was much lower. And we have to keep in mind that Crystal AF and the Embrace they're completely different populations. And also another factor is that the implantable cardiac monitor does not detect episodes of AFib that are under 2 minutes. So if there's a very brief episode of AFib under 2 minutes, the implantable cardiac monitor may not sense it. Whereas the event monitor or the MCOT, the mobile continuous telemetry, cardiac telemetry, can detect episodes of AFib that are up to 30 seconds, that are 30 seconds or longer. So this may have played a role in why we have increased detection of AFib in the first 30 days in the Embrace trial using the 30-day monitor versus the first 30 days in Crystal AF. But also there are two different patient populations. So, in Crystal AF, they really excluded a lot of patients who, and perhaps, some physicians would anticoagulate them off-label, if they had a severely dilated left atrium or if they had like spontaneous echo contrast in the left atrium, they would not have been included in Crystal AF. And these patients are probably more likely to have AFib, but they would have been included in the EMBRACE trial. So they're completely different patient populations, and that may be why the rate was very low in the first 30 days in Crystal AF, but also, as I said earlier, the insertable cardiac monitor doesn't pick up episodes of AFib unless they're 2 minutes or longer, so it may have missed some brief runs of AFib that happened that may have been picked up by a 30-day monitor. So, but yes, to answer your question, the longer you monitor, the more likely you detect AFib, and you know, I typically do the 30-day monitor first and then do the insertable cardiac monitor, whereas, you know, others start with the insertable cardiac monitor and some do the 30-day monitor only. As the last slide says, we don't know what the optimal timing of monitoring, but we know that the longer you monitor, the more likely you're going to find AFib, and finding AFib really identifies the best antithrombotic treatment for patients.
That's really helpful information. Thank you for sharing that. And I guess that would lead me to my next question then. If we capture incidents of AFib that are less than 30 seconds, or I guess that are about 30 seconds, like you said, is that considered an acceptable reason to put a patient on an anticoagulant, or is that, so any run of AFib would be a good reason to put them on an anticoagulant?
That's a great question. You know, I'd say, like, for secondary stroke prevention, and again, this is my practice, it's not, there's no good evidence to support it, but if someone has any AFib after a cryptogenic stroke on their cardiac monitor, I typically anticoagulate them. Again, this is controversial. It's not something that we have good evidence to support, but we know that probably 5 minutes or more of AFib has been shown to be associated with increased risk of stroke. That's from the ASSERT study. And now there's a clinical trial going on looking at anticoagulation for brief runs of AFib with apixaban versus aspirin, brief runs of subclinical AFib. So we'll have an answer on that, but again, this is a very controversial topic. If you know, someone has very brief AFib, whether we should anticoagulate them or monitor them longer and wait until we find longer episodes of AFib. But one thing, you know, I must say is, if the episode was under 30 seconds, it's very hard to prove that it's AFib versus supraventricular tachycardia. So I think, you know, I tend to monitor them longer and be certain that it is AFib before I anticoagulate them.
Thank you. Very helpful.
Yeah, of course.
We do have a couple questions in the chat box. What are other causes of cryptogenic stroke other than AFib?
Yeah, that's another great question. So there's AFib, there's aortic arch atherosclerosis, and there's a patent foramen ovale, or a hole in the heart. So these are potential causes. There are obviously a big list of causes, but these are the most common causes: PFO, aortic arch disease, or substenotic atherosclerotic disease, or atrial fibrillation.
Thank you. And what duration of AFib would be associated with increased risk for stroke?
Yeah, so another great question. It's controversial, and you know, but we know that in the ASSERT study, 5 minutes of AFib or longer was associated with 2.5 times increased risk of stroke. So, so for now, you know, the data shows that 5 minutes or longer, but even, you know, there are studies, there's mixed data about shorter and briefer runs of AFib. I think we don't have a good answer for brief AFib, but for AFib that's 5 minutes or longer, it's been shown to be associated with increased risk of stroke.
Great, thank you. We do have another one.
Yeah.
Studies that increased risk of stroke PR interval and increased age. What age is considered increased?
So in this study, they looked at age as a continuous variable. It's more like, I don't recall what the odds ratio was for AFib, but for age, what the odds ratio that predicts AFib, but it's more, it's just increasing age, and they use age as a continuous variable. Other studies have divided age into two categories, 60 to 75 and more than 75, and other studies looked at under 60 and over 60. So it's more, the older someone is, the more likely they're going to have AFib. And I don't think there's a point in age where the risk tremendously goes up versus, a year before. It's more just as we get older, there's an increased likelihood of AFib.
Great, thank you. Again, if you guys have any other questions, come off mute by pressing *6 or type in the Q&A section of WebEx. What are your thoughts about new studies suggesting low-dose ASA with one of the NOACs?
For atrial fibrillation? So low-dose aspirin plus a NOAC for stroke prevention and AFib?
I believe so. She didn't say.
I'm not sure that there's much data to support adding aspirin to a novel anticoagulant for stroke prevention in AFib. In the novel anticoagulant studies, the Aristotle and the RELY study and the study on rivaroxaban, Rocket AF, most patients were taking an antiplatelet agent in addition to the anticoagulant, either the novel anticoagulant or warfarin. We know that the addition of aspirin to novel anticoagulant increases the risk of bleeding and may not provide much of stroke prevention benefit. However, there are certain patient populations who may benefit from adding aspirin or an antiplatelet agent to an anticoagulant. Mainly patients with atherosclerotic disease, either coronary heart disease or peripheral vascular disease, who may benefit from adding an antiplatelet agent to an anticoagulant if they have AFib, especially if they have a cardiac stent. But in general, for secondary stroke prevention, if someone has AFib, we tend to only keep them on the anticoagulant and not add an antiplatelet agent.
Well, thank you. If there are no more questions, we would like to thank Dr. Yagi one more time. And a couple reminders before signing off. Please note you will only be able to claim your CE credits at the end of the 15-week series on September 27th, and a copy of today's slides and handouts will be sent to you within a week of today's call. Again, thank you guys so much for signing on, and we will see you next week.
Thank you so much.
Thank you.